got a question, do we need an NSAID? What about a steroid only? And if you look at data, we'll see the next slide here as well, the data supports that actually the NSAID alone or the steroid alone doesn't do quite as well as the combo. This is at 6 weeks and 12 weeks, looking at the combination here of the NSAID and the steroid, this is for specifically CME. There's other data looking at inflammation and pain control that the NSAID and the steroid tend to work best together, especially in the context of CME as well. So I use both in pretty much all my patients in general.
And I think the other point is, if you were going to use just one, the NSAID is actually the more important of the two. So if you had decided you were going to just use either a steroid or NSAID, the NSAID would be my preference.
So we have available to us right now, right? We have antibiotic intracameral moxie that I think a lot of us use to decrease the post-operative antibiotic use, and then we have different versions of steroids that we use, intracanalicular steroids here, dexamethasone, we have subconjunctival triamcinolone acetonide. But in the NSAID world, we didn't really have a lot of options, except for now recently with OMIDRIA.
If we went dropless, which many of us already use intracameral antibiotics, so that was a no-brainer. We were doing that already. But we also used anti-inflammatories that were depot, so triamcinolones subconjunctivally, and then OMIDRIA as our depot NSAID. Could we have the same efficacy, the same patient satisfaction, the same improvement in visual acuity, and really none of the things that we were worried about, like IOP spikes or retinal thickening or increase in inflammation, that we might be worried would happen if the patients were participating in a topical regimen? And here's the inflammation data. So these are preliminary data. We don't have all of our patients enrolled yet. But what we're seeing is exactly what we expected to see. None of these bars are statistically significantly different. We have about the same number of patients in each group. We have 64 in the study group and 66 in the control arm. And what we saw is that on day one, patients with inflammation, just about the same number in either one. And the average grade of inflammation, just so you know, as we anticipate with modern cataract surgery, was fairly low, but it was statistically the same in both groups. And with the primary endpoint of 1 week or day 8, it's the same in each group. And really, none of the patients in either group had any inflammation at day 30, which is exactly what I would anticipate from how we perform modern day cataract surgery.
We found that, yes, you're going to be as safe as topical medications, but are there any additional benefits to the patient satisfaction, the actual post-operative period of time? First of all, we all know how important cost is. Even trying to get drops, even generic medications. I mean, in our market in Wisconsin, generics aren't $5. They're $30, $40, and sometimes we're paying well over $100. We saw here, even for generic medications, $146 in the study arm, they saved by not having to use drop. And so because they had to pay for the drops in the non-OMIDRIA arm. So this is real life data showing how much our patients have to take or pay even for generic medications. This I thought was probably the most important part of this, outside of the inflammation and thickening of the macula, was this. I mean, kind of what we anecdotally thought would be, but 90% of patients in the study arm, the OMIDRIA arm, were highly satisfied versus only 42% of our patients in the topical drop control arm. This is not my quote, this is from your office, but we heard this all the time. And as a glaucoma specialist, I deal with this every single day. And why I'm so big in the whole MIGS and SLT world, et cetera, is because this is something that we see every day in glaucoma. And post-op cataract surgery is no different. If you ask patients, do you take your medications, they're always going to say yes. No one ever says no. But when you really get into it, are you taking them how you should take them? 5 minutes apart, 4 times a day, or twice a day, whatever it is. They don't. And so this is what, for me, was huge. Look, at the end of the day, we do see the inflammatory cascade during the surgery itself while we're causing the insult to the injury to the tissues. We're having an NSAID calming that inflammatory cascade. As Brian, I'm going to use that fire analogy all the time now. Thank you. And I'll give you credit for that one. But also, just being able to not, use topical medications did not negatively adverse the outcomes from an inflammation, CME, retinal thickness. And again, 3-month data will be coming out as well to show that as well, more than just 1 month. And at the end of the day, I think the patients do want to not have to take medications. They prefer it far over topical medications.
All of the things that we learned from this study and from our use in the clinic in the OR with OMIDRIA is we know that it helps maintain pupillary dilation during cataract surgery, which is going to reduce our incidence and need to utilize pupillary expansion devices, which is going to mean we annoy the iris less, which is going to mean we're going to have happier eyes post-operatively. Additionally, we know that if we combine that with some form of depot of steroid, we are now able to get these patients off of drops altogether in a really safe and effective fashion that they prefer. That would be my take home.
Yeah, and I would say that a focus on the patient experience, a focus on enabling our patients to have that really wow experience, taking the burden of their postoperative care and their healing away from the patient, putting it back in control of the physician is great for the physician. It's great in reducing my stress and worrying about the postoperative period. It reduces my stress of doing the operation because of that stability of the iris, and it provides less stress for the patient and having to follow your instructions. So overall, we're all happier. And like I like to say, you know, happy patients make happy surgeons, but happy surgeons make happy patients too.